You're welcome to my channel. Thanks for visiting. I'll be addressing respiratory failure, and today I will go over type 1 respiratory failure fully. Without further ado, let's go. Let's quickly define some terms in respiratory failure generally. What is respiratory failure? Normally, we will all breathe in oxygen and breathe out carbon dioxide. But in respiratory failure, that normal cycle is now impaired. Something is wrong. It's either we are not ventilating fully anymore, and then we are dealing with low level of oxygen to the blood, or we don't have the capability to breathe out the CO2 fully. Then we will have decreased oxygen in the blood and decreased oxygen supply to the organs. We will then be battling with metabolic derangement. Kidneys will be recruited to help. And why that? When there is impairment in this cycle, decreased oxygenation, increased carbon dioxide retention will be faced with low pH. That will be respiratory acidosis. Further drop in the pH could be detrimental to the health of anyone. So the kidney will be recruited to help in achieving compensation, and the kidney will be supplying bicarbonate. So that is all about respiratory failure. It could kill, sure. Now, we will briefly go over the 4 different types of respiratory failure. In type 1, it will be limited to hypoxic respiratory failure, in the sense that less oxygen is getting to the tissues. Don't worry, I will go into details of that one right here, right now. Hypoxemia, that is type 2, meaning there is more CO2 produced but not getting out. And type 3 is all about around the time of operation. So I target operation related or perioperative condition. While type 4 respiratory failure is all about shock, either hypovolemic shock or septic shock or cardiogenic shock. In general, shock leading to hypoperfusion of all organs. You remember, when you are dealing with shock, there's a stage when it is pretty bad, there will be multiple organ failure. In this case, when shock is leading to the failure of respiratory system, then that will be type 4 respiratory failure. Now, let me define type 1 respiratory failure fully. If you go to some literature or textbooks, it could be written as hypoxic state or hypoxemia. What? That's right. Hypoxemia and hypoxia could be used interchangeably, but they are not the same. However, hypoxia will not occur without hypoxemia. Okay, what is hypoxemia? Hypoxemia means there is low level of oxygen in the blood. And hypoxia means there is low level of oxygen supply to the tissues, giving us hypoxic state. So, hypoxemia will first of all occur, and the impact of hypoxemia, or the impact of the low level of oxygen in the blood, is that the organs or tissues will become starved, starvation of tissues. That is hypoxia. Let's check the partial pressure of oxygen that would determine hypoxemia. Anything lower than 50 millimeters of mercury, or many authorities will even put it as partial pressure of oxygen lower than 60 millimeters of mercury, is enough to say there is hypoxemia here. We are dealing with type 1 respiratory failure, because the normal range is 75 to 100 millimeters of mercury. Remember, the partial pressure of oxygen is the amount of oxygen dissolved in the blood, and it is reflecting the strength of the lungs to pull oxygen into the blood. Now, we will check another parameter under type 1 respiratory failure. That is O2 sat. Normally, we expect anyone without any lung-related condition to have 95 to 100% O2 sat, which is the amount or the number of hemoglobin that is carrying oxygen. So any level less than 94% will qualify O2 sat to be under type 1 respiratory failure. Some authority will put it as less than 90% before we can say this is hypoxemia. Then, this is not necessary. I mean, CO2 level is not necessary, but without defining it, we will not be defining type 1 respiratory failure fully. The CO2 level under type 1 respiratory failure is unaffected. It will be within the normal range of 34 to 45 millimeters of mercury. So in summary, there is low partial pressure of oxygen, O2 sat is down, then we are dealing with hypoxemia, low level of oxygen in the blood, and then the tissues are becoming starved. They are no longer getting enough supply of oxygen at this hypoxic state. So that is the end of type 1 respiratory failure by definition. Now, let's go over the possible causes of type 1 respiratory failure. We can just check the oxygen delivery tube for kinking or blockage if the individual is already under. And then we should ask ourselves, is this patient high up? No, is this a mountain climber and on top of the mountain? Or just high altitude, generally? If that is the case, that may be responsible. Is it that this individual is not breathing enough? Hypoventilation. That could be deliberately done, or could be as a result of pain or damage to respiratory muscles or diseases. Okay. Is this individual on IV fluid and now having pulmonary congestion or pulmonary edema? We should check that. Any trauma in this individual with bleeding into the lungs? Any fever here? Is the chest X-ray revealing opacity? Are we dealing with pneumonia? Is this individual in respiratory distress? Or are we battling with probability of lung collapse here or atelectasis? Are we dealing with pulmonary embolism? Could this be ventilation perfusion mismatch? It might be a kind of right to left shunt, no, or diffusion problem. Any GBS, Guillain-Barré syndrome, myasthenia gravis, or ALS, all these things should be checked in anyone with type 1 respiratory failure. Then if we are able to get to the bottom of the problem, then let's solve it and let this patient be fine. So check the airway, please, for foreign body, secretion, and suction as it may be appropriate. Now, let's call pulmonologist. Depending on the level of O2 sat and if we are unable to get the cause, we must give oxygen. Remember, we are dealing with hypoxemia, giving us hypoxic state right now. Then, what else are we going to do? This individual must be resting in prone position. Yes, we can give nitric oxide, and if there is fluid in the lungs, like having fluid and congestion, right? Let's get the fluid out. Let's look for high saline diuretics, like furosemide, Lasix, right? Then we can then rest the whatever other interventions in the hands of pulmonologists or has been directed by pulmonologists, like pressure control ventilation, PEEP, and then allow for retention of CO2, otherwise known as permissive hypercapnia, as whatever the pulmonologist may suggest. With that, I've come to the end of this short presentation on type 1 respiratory failure. The next presentation will be on type 2 respiratory failure, which is all about CO2 retention or hypercapnia or decreased ventilation. Thanks for listening. Please remember to subscribe to my channel. I appreciate that.